Very good morning to one and all present here. I would like to thank the AOS committee for giving us this opportunity. And I will be talking about the anatomy, etiopathogenesis, and the classification of Descemet's membrane detachment. So, going by a brief anatomy, the Descemet's membrane is located in the posterior stroma and it measures about 8 to 10 mm in thickness. And it, along with the corneal endothelium, helps us in maintaining the transparency of the cornea. A brief histopathology. It's consisted of three layers. One is the non-banded layer, which is the thinnest, measures about 3.3 mm, and it's present just adjacent to the stroma. Then followed by the anterior banded zone and a posterior non-banded zone. The posterior non-banded zone measures about 4 mm and it represents about two-thirds the thickness of the Descemet's membrane. It's mainly made up of collagen type 4 and type 8. It is also made up of other non-collagenous substances such as fibronectin, laminin, nitrogen, vitronectin, and it's also made up of other proteoglycans such as your keratin sulfate, the heparin dermatin, and chondroitin sulfate. So the etiopathogenesis, the Descemet's membrane detachment is a serious complication following cataract surgeries, and it has been characterized as a potential visual threatening complication, and it's reported to occur in almost 43% of all cases following cataract surgery. DMDs can also occur in any anterior segment surgery, such as your iridectomy, trabeculectomy, viscocanalostomy, vitrectomy, or any corneal transplants. It can also be found in some cases of chemical injuries as well. Most of the DMDs are not vision threatening and they resolve spontaneously after the procedure. And the characteristic clinical sign is a severe persisting corneal edema after the surgery without any spontaneous improvement. So, a hammock configuration, which is usually seen in a slit lamp, starts at the corneal ports of entry and is due to injections due to hydration. So, the fluid enters the potential space between the posterior stroma and the DM, separating the DM into various extents. And the detachment may be associated with the DM separation due to entry of fluid into the interface. The most severe kind is a complete tear separating the detachment into multiple flaps due to any iatrogenic trauma due to blunt instrumentation or during delivery of the nucleus in case of an SICS. The major risk factors can be classified as pre-op, intra-op, and post-op. In pre-op, any pre-existing conditions such as corneal neovascularization, old age of the patient, a dense cataract, or any previous history of chemical injury. Intraoperatively, in any clear corneal incisions, if the incisions are small or rugged, any blunt instrumentation or frequent instrumentation, any inadvertent damage by the instruments, and in case of phaco, when the ultrasound time exceeds more than 60 seconds. Post-operatively, if there is any abnormality in the Descemet membrane stromal interface, any corneal ectatic disorders or endothelial disorders such as your Fuchs. So going by the classification, we have the Samuel's classification of DNB, which is classified as active, passive, and combined. So in active detachments, it's also known as the pushed back detachments. So this occurs due to any active exudation between the stroma and the DM, which pushes the DM backward. In a passive detachment or a pulled back detachments, this occurs due to any organizing exudates or heme present in the anterior chamber, which draws the DM into the anterior chamber away from the stroma. And then there are detachments because of the difference in elasticity between the stroma, that is the stromal parenchyma, and the glass membrane, causing the Descemet's membrane to roll on itself or form folds. Then we have the macule classification. This is divided into planar and non-planar. When the separation between Descemet's membrane from its overlying stroma is about less than 1 mm, we classify it as planar, and non-planar when it is more than 1 mm in any area. Obviously, the planar has a better prognosis than the non-planar. Both the detachments are further classified into peripheral and combined. So, in peripheral detachments, the peripheral 3 mm of the cornea or the DM is involved, and in combined detachments, both the periphery and the center is involved. Next is the Jane's classification. So Jane's classification is divided into mild, moderate, and severe. That is less than 25% of the cornea, from 25 to 50% and more than 50% of the cornea. And good prognosis were observed in cases of air compared to C3F8, and poorer prognosis was seen in cases of advanced cataract, prolonged duration between the cataract surgery and any surgical intervention, and cataracts with pre-existing corneal opacities. Moving on to the HELP algorithm. So this algorithm is basically dependent on the classification using ASOCT, that is the anterior segment OCT. And this is useful for us to diagnose and plan the treatment protocol and also the prognosis. So it can be divided into three categories. First is HELP, stands for the height, the extent, the length, and the pupillary involvement. So in case of the pupillary involvement, it can be classified into three zones: zone 1, 2, and 3. Zone 1 involving the center, zone 2 involving the mid periphery, and zone 3 involving the far periphery. So the first one, when the height is less than about 100 microns and the length less than about 1 millimeters, when either of the zones are involved, 1, 2, or 3, we can go ahead with the medical management. Second category, where the height is between, so all these measurements are based on the ASOCT. So when the height is between 100 to 300 microns, length somewhere between 1 to 2 mm, again we classify it as zone 1, 2, and 3. Zone 1, whether the pupil is involved or not. If the pupil is involved, then surgical intervention would be the method. If zone 2 and zone 3, then we can follow medical management. If the medical management doesn't subside within 4 weeks of commencement of the treatment, then we can go ahead with the surgical management. The other criteria is height less than 300 microns, length more than 3 mm. If it is zone 1 and 2, surgical intervention is recommended. Zone 3, we can still observe medically, and again, if it does not resolve, we can go ahead with the surgical management. So this is an ASOCT picture of height about 100 to 300 microns, length approximately 2 mm. Zone 3, that is the far periphery, is involved. So going by this classification again, we can follow a medical management. So the first image is of a height less than 100 mm, length less than 1 mm, and zone 2 involvement. We can go in for a medical management. Again, the second picture is of a height less than 100 microns, length approximately between 1 to 2 mm, zone 1. So though the center is involved, since the length is quite small, we can still try for medical management. This is coming to the Jacobs classification. This is very analogous to the retinal detachment classification that we have. It is the Descemet's membrane detachment is classified into 4 criteria. One is the rhegmatogenous, tractional, bullous, and complex. So in rhegmatogenous Descemet's detachment, it's usually because of any hole, tear, or dialysis in the DM. And any small clinically insignificant tears, we can observe the patient. However, clinically significant tears such as involvement of the visual axis, we can go in for a surgical treatment such as pneumatopexy or fluid drainage, depending on what the cause of the DM is. Going to the tractional detachment, we have the tractional detachment is because of any incarceration of the DM into any sutured corneal wound, which causes a traction pulling the DM. Again, if it is small, we can observe the patient. However, if it is clinically or visually significant, we can go in for a surgical management. Any long-standing rhegmatogenous detachments can also lead to a tractional detachment because of the traction. Going to a bullous detachment, this is because of any fluid injection between the corneal interface and the DM. So the fluid can either be a viscoelastic or during hydration. If it is again visually insignificant, we can observe and then go in for a surgical management if it is visually significant. Complex detachment usually occurs in any post-endothelial grafts. So this is when the graft rolls on itself, leading to a complex presentation of the DM. So this is an example of a rhegmatogenous detachment. Usually in the rhegmatogenous detachment, there is separation from the posterior stroma and there is free floating of the DM in the anterior chamber. This is an example of a tractional detachment. So in a tractional detachment, the either ends of the DM is still attached to the posterior stroma and the DM presents as a taut membrane. So this is the adjacent picture is that of a slit lamp image of a patient. So this patient had an incarceration of the DM in a sutured corneal wound. So center we can see the detachment, and in the periphery we can see the attachment to the stroma. This is a bullous configuration of detachment. The center can either be filled with a fluid or it can be filled with any viscoelastic material. So, while going in for a diagnosis, these are the following things which we have to keep in mind. A thorough slit lamp evaluation and an ASOCT is pertinent for us to plan our treatment. So, the configuration of the tear or the detachment is usually seen in an ASOCT. The material causing the detachment, in case of a viscoelastic, we need to do a drainage of the fluid, presentation of the DM, and also area and extent of the detachment. We should also be able to find out any areas of missing DM. So these features help us in surgical planning and in predicting the prognosis. So I would now like to hand it over to Dr. Preeti, who will be talking about the management of the detachments.
Thank you, Ranjita.
Thank you.